The topic allotted to me is renal issues in CHIP PCI. The commonest and most important renal issue in CHIP PCI is contrast-associated acute kidney injury. It is an impairment of renal function which occurs within days of intravascular administration of iodinated contrast media. And it is associated with increased short and long-term mortality and MACE. Data from the NCDR CAT PCI registry showed that this data included more than 9.8 lakhs patients, and there was a 7.1% incidence of acute kidney injury, and dialysis was required in 0.3%. And the incidence was related to some patient factors and some contrast-related factors. The most important patient-related factor was baseline renal function. Others were advanced age, diabetes, anemia, and elevated uric acid. Among the contrast-related factors, both qualitative and quantitative characteristics of the contrast influence the incidence. This shows the various risk stratification models to evaluate the risk of an individual. Among this, Mehran 2 risk score is a promising risk score which is based on 8 clinical variables. And there are two models, Model 1 and Model 2. Model 1 is based only on preclinical variables, and Model 2 is based on preclinical and clinical variables. And we can find out the score from the graph. The most common definition used in clinical trials is an increase of serum creatinine of 0.5% or a 25% increase from the baseline within 2 to 5 days of the procedure. So creatinine is presently the primary tool to assess renal function, but it has many limitations. So alternative biomarkers have been proposed. Most important were NGAL and cystatin C. Cystatin C is approved by the US FDA. Although many new biomarkers have been proposed, creatinine continues to be used because of the availability, low cost, and the amount of data in the literature. This shows the pathophysiology. Contrast media is directly toxic to the tubular epithelial cells. High osmolar contrast media is the most important. It gives rise to reactive oxygen species, and this reactive oxygen species produce vasoconstriction, leading on to hypoperfusion of the medulla. The isoosmolar contrast media also lead to medullary hypoperfusion. And the activation of the sympathetic nervous system, RAS, and tubuloglomerular feedback leads to, again, vasoconstriction, contributing to the medullary hypoperfusion. And concomitantly administered drugs can also produce acute kidney injury. So, the contrast-associated acute kidney injury is produced by a host of concomitant factors rather than to contrast media alone. There are multiple factors that are involved. So regarding the clinical implications, contrast-associated acute kidney injury is associated with prolonged hospitalization, acute renal failure, cardiovascular events, and mortality. It is also associated with a sustained reduction in renal function leading on to chronic kidney disease. However, the relationship between mortality and the contrast-associated acute kidney injury is strongly confounded by many clinical variables, the baseline clinical characteristics. And there are clinical characteristics that affect both mortality and acute kidney injury. So, a discussion arose whether contrast-associated AKI is a marker of such adverse outcome or a mediator of such adverse outcome. And recently, a meta-analysis has showed that a reduction in AKI incidence is failed to reduce the long-term mortality and the development of chronic kidney disease. So, whether a marker or a mediator, given the current uncertainty regarding the causal relationship between contrast-associated AKI and the adverse outcome, we should not exclude patients from invasive procedures just to avoid AKI, and we will have to take all measures to prevent AKI from developing. Now let us look at the preventive measures. First, minimal amount of contrast should be used. Avoid high osmolar contrast media. All non-essential nephrotoxic medication should be discontinued. In this context, an important question will be, does this include RAS inhibitors? And the answer is, there is non-convincing data to support its discontinuation. The discontinuation of metformin is recommended because it produces lactic acidosis, which can lead to acute kidney injury. And other drugs to be discontinued are NSAID, beta-lactam antibiotics, aminoglycosides, and sulfonamides. The intravascular volume expansion plays a key role in the prevention of AKI. It avoids renal hypoperfusion, suppresses RAS, tubuloglomerular feedback, and vasopressin. It supports urine flow rate, a high urine flow rate, and lower the concentration of contrast media in tubular cells. And the current European guidelines recommend hydration with 0.9% sodium chloride at 1 to 1.5 ml per kilogram per hour for 12 hours before and 24 hours after. So these recommendations are really basic, and the Poseidon trial demonstrated that expanding the plasma volume by measuring LVEDP give better result, and the Quinn et al. Suggested RA pressure to monitor the plasma volume. Regarding the pharmacological strategies, agents such as N-acetylcysteine, aminophylline, trimetazidine, and phenoldiazepam were found to have some effect in reducing the acute kidney injury in smaller trials, but larger trial fails to demonstrate any of this. And high-dose statin has been found to reduce the AKI. There are many mechanisms proposed, and the current guidelines recommend the use of high-dose statins before PCI. Remote ischemia conditioning is a method that applies brief episodes of ischemia, reperfusion to an organ or tissue that is remote from the target organ, and a radial access should be preferred to femoral access. The AKI matrix study has shown that the incidence of AKI is reduced in those with radial access when compared to femoral access. The exact reason is not known. It is thought to be due to a reduction in access-related bleeding. So in conclusion, contrast-associated AKI is the most important renal issue in CHIP PCI. It is linked to a set of concomitant causes rather than to contrast media alone. And Mehran-2 risk score is a promising tool to find out the susceptible patients. And there is uncertainty regarding the causal relationship between AKI and the adverse outcome. And we should not deny treatment just to avoid AKI and take all preventive measures. This shows the preventive measures in nutshell. Those given in green are already established ones. Those in yellow are controversial, and those in red not recommended. Thank you for patient hearing.
Thank you, sir, for a nice talk. In a routine practice, when we face an acute coronary syndrome with acute kidney injury, all the available pharmacological agents to prevent the acute kidney injury is not found to be useful, like N-acetylcysteine. And in your clinical practice, when you see a patient with acute kidney injury and acute coronary syndrome, what you will do in that setting? to prevent renal worsening, other than reducing the contrast? Any other? Because all the other available...
Reducing the contrast
Yeah, yeah.
and taking the least toxic one, then fluid, sodium chloride is the best one recommended. Then if possible, stop all the offending drugs if there is. So these are the methods that can be taken.
Unfortunately...
And even after the procedure, we'll have to continue the hydration for 24 hours.
Most of us still give N-acetylcysteine despite lack of evidence. There is some belief it's harmless and it may benefit, I'm not sure. Dr. Ajit?
Yeah, one thing in a chip case is to reduce the contrast. And we published this now in International Journal of Cardiology on zero contrast PCI with IVIS.
Yeah.
And right now we are running a randomized trial on anybody with a 60 GFR and low of zero contrast versus low contrast. So I think this is very important that because in a chip you need to have images some way, and obviously dye will inject. And unless you do that, you know, the problem of renal complications will arise.
So again, the question to you and maybe to the experts, that if you have a creatinine of 4+, patient is volume overloaded, presents with ACs. I have a patient right now lying in my ICU. Do you start dialysis and take up, or do you wait for the, I mean, that's a challenging question at times.
Yeah, I think if it's a fluid overloaded patient and dialysis, 4 is a creatinine, I don't think we need to that much worry. Anyway, is dialysis dependent. We need to get on the dialysis, get on. Is the problem with the borderline renal function, especially 60 GFR around that. That's the ones which you may push a patient from no dialysis into dialysis. And that's sort of very traumatic for the patient and for yourself to push a patient into dialysis. So there is where you need to be very, very careful about the contrast volume.
Because they'll always say after that angio patient became dialysis. That's a challenge we always face day in, day out. I'm sure many of you have faced that situation. Comments?
Contrast management is very important. It's a part of complex PCI, which is again subspecialty of our main specialty. I invite everyone start practicing special techniques in the normal daily PCI by creating roadmaps with wires. There are so many techniques, especially if you use IVUS. And if there is a previous angiogram available, you just say thank you very much and move in those projections put in front of you. For example, the case we saw yesterday with 140 mils of contrast could easily be done with 20 mils without even trying to reduce the contrast volume load. If you really wanted to do it without contrast, you could do it with zero contrast. But of course, you have to do one final shot just to make sure no distal bar curves, etc. I was guided, that's good enough. And what I also saw in many PCIs demonstrated here quite often, just after ballooning, there is injection, after stent, there is injection. I don't understand why it still needs to be done if you use IVUS. All you do is just after those OPN, after cutting balloons, etc., you just stay back 10-20 seconds. If there was no ST changes, if there is no pain syndrome from the patient, unless patient is intubated and under anesthetic, then you can go ahead. You know, injecting after each step is kind of part of the past, I think. When there was no imaging, when there was no covered stents, etc. You know, things change, and by improving our techniques, we will be doing more better complex PCI.
Thank you. So the message is reduce contrast as much as possible. Thank you, Dr.